Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Mary Maish, MD. Dr. Mary Maish is a thoracic surgeon with the Washington Township Medical Foundation. Dr. Maish received her medical degree from Rush Medical College in Chicago. She completed her surgical internship at Rush Presbyterian St. Luke's Hospital in Bethlehem, Pennsylvania. She did her surgical residency at Michigan State University in East Lansing, Michigan, and at the University of Pennsylvania, St. Luke's Hospital in Bethlehem, Pennsylvania. And she did her cardiothoracic research fellowship at Brown University in Providence, Rhode Island. Dr. Maish received a Master's of Public Health from Harvard University in Boston, Massachusetts. She did her thoracic surgery residency at Baylor College of Medicine in Maryland and at the Cancer Center in Houston, Texas. She completed her Foregut Division Clinical Fellowship at the University of Southern California. Dr. Maish is board certified by the American Board of Surgery and the American Board of Thoracic Surgery.
My goal is to help you understand why reflux occurs, when it is troubling and you should pay attention to it, and when it is not. And then also to give you some information on how you can do some self-medication, self-diagnostics, and then know when you should be seeing a doctor for more severe symptoms and going on to get better advice. Finally, we'll talk a little bit about the risk of going on to have esophageal cancer if you have reflux disease, and talk very briefly about the ways to recognize some of those signs and symptoms. So not surprisingly, I'm sure many of you would understand that 44% of Americans will experience heartburn at least once a month, and I'm sure many of you in this room are participating in those statistics. And in fact, 7 to 10% of us are experiencing it every single day. So that's a very significant percentage of the population, and indeed it's the second most common reason why a person will go and see their primary care physician after the common cold, flu, upper respiratory type symptoms. It is a serious medical condition, and it can produce a wide variety of symptoms and also complications. So it's what we need to know about it to understand when it's severe. So what is it exactly? Well, a brief anatomy lesson. We have an esophagus that goes through the center of our chest, and it joins our stomach just after it passes through the diaphragm. The diaphragm acts as a pressure change. So we go from a negative pressure in the chest to a positive pressure in the abdomen, where the stomach lies. And this pressure change allows for there to be a closing of the lower esophageal sphincter, or the valve that's between the esophagus and the stomach. This schematic helps you to see exactly where that valve lies. It's right between where the esophagus meets the stomach. And although it has no true anatomic position, it varies in many individuals, it does have a pressure change. And at that point, we will see the pressure in the esophagus rise slightly over the pressure in the rest of the esophagus, unless we're eating. And then, of course, it opens to relax the valve, and the pressure will go down to allow food then to pass into the stomach. In reflux disease, this valve becomes incompetent. It no longer functions the way that it's supposed to behave. So in the general population, your valve should be closed most times of the day, unless you're eating, swallowing, or having an occasional opening to have a relief of gas. In people that have reflux, even mild or moderate or very severe reflux, what you're going to see is that that valve remains open the majority of the day, and it allows for the acid then that normally rests in our stomach to turn around and back up through the pipes into the esophagus and eventually cause heartburn or that bitter bile taste in the back of your mouth or regurgitation of material. So you can see here when there's a normal valve, it keeps things nice and tight. When the valve opens, stomach acid can then back up into the esophagus, causing heartburn. So when we think about gastroesophageal reflux disease, we know that one of the causes can be that the valve is poorly functioning. It's weak. And as a result, we have refluxing of irritants. Sometimes this is acid, sometimes this is bile, and then there's a myriad of other things that it can be, such as pepsin, pancreatic juices, and what we had for lunch earlier today. But there are other things that can also cause gastroesophageal reflux disease, and that includes the inability of the esophagus to squeeze properly, or what we call poor pump, poor motility, or else delayed gastric emptying. That's when the stomach doesn't actually empty properly. So these are also things that can lead to the same symptoms of gastroesophageal reflux disease. So the next question is, well, why is the valve weak? To be honest, most of the time we don't really know. There isn't a whole lot that you can do to make it weak, but there are some things that, that you can do to prevent it from getting weak over time. There are some disease processes, such as scleroderma, which you have no control over, which can cause the valve to become stiff. You can also have a hiatal hernia, which is where the top part of the stomach pushes its way up through the diaphragm and now rests in the chest as opposed to under the diaphragm in the abdominal cavity. These things can most certainly cause the valve to become weak. This is a schematic to help you understand what a hiatal hernia is. The picture on the left shows that the esophagus travels through the chest, goes underneath the diaphragm, and not until it's underneath the diaphragm does it actually join the stomach. But the diagram on the right shows you how the esophagus travels through the chest, and then before it reaches the diaphragm, it joins the stomach. So a small portion of the stomach has pushed its way up through the diaphragm and joined the esophagus and the chest. This now causes a pressure differential that is not normal. Usually, that connection between the esophagus and the stomach is in the abdomen, where there's positive pressure pushing down on that valve to keep it closed. But in this instance, when you have a hiatal hernia, the pressure in the chest is negative and it's pulling open the valve, causing ongoing reflux disease. So how do we know if we actually have GERD? Well, there are a constellation of symptoms, which many of us know about. And then, of course, there's objective measures, things that the doctors will tell you you need in order to make sure that what you're experiencing is reflux disease and not some other problem. The symptoms most commonly are heartburn, but it's not always present. It's present about 85% of the time. But typically, we see other things as well, like regurgitation or epigastric pain. Some people may even think it feels like a heart attack. Sore throats, nausea and vomiting occasionally if it's very severe. Even weight loss for patients that are stricken by the pain so much they're unable to be eating properly. And then there are some atypical symptoms. Those patients that have regular asthma attacks, recurrent pneumonias and bronchitis, nighttime symptoms, coughing in the middle of the night and waking up with uncontrolled coughing, dental decay, ear infections, foul breath, hoarseness and changes in your voice. All of these can be early or initial signs of reflux disease. So what do we worry about? Well, dear colleagues, this is definitely the most severe case of heartburn I have ever seen. So what we don't want to find is ourselves on the operating room table for this disorder. So how can we prevent that? Well, traditionally, heartburn has always been treated medically. And over the years, as the medicine has improved, it's been treated increasingly more with medications. However, just because you take a medicine doesn't mean that you're actually going to fix the problem. The problem is that we have material in our stomach that is backing up into our esophagus because the valve is weak. And even though we may take away the symptom of heartburn or regurgitation, we may take away that with some of the medicines that we use, we may not take away the problem. It still may be regurgitating. It may be refluxing continuously, only now if we're taking antacid medicines, it won't have any acid in it, so we won't feel it. But the inflammation can continue even if you're taking the medications. One of the problems can be esophagitis. That's just inflammation. That's like taking your fingernail and scratching your skin, but instead you're scratching the inside of your esophagus, pouring a little bit of acid in there and making it look red. It hurts because it's inflamed. It's a chemical burn. Over time, the body changes the inflammation to scar. Chronic inflammation causes scarring. And with scarring in the esophagus, that will cause some narrowing. And the narrowing takes care of the problem because now the valve is narrowed. It's smaller, it has a little bit more pressure to prevent all that material from refluxing back up into the esophagus. However, now you're going to have difficulty swallowing because things don't pass easily through the scar. So perhaps it's going to help the acid prevent that from coming back up. But now you're going to have a problem of not being able to swallow regular food. So we call this a stricture. This is where the inflammation has then been replaced by scar tissue. And if it's severe enough, it can lead to what we call dysphagia, or severe difficulty eating, where food gets stuck and may require trips to the emergency room to disimpact the food. Now, what if you have a normal functioning valve, but your esophagus doesn't function properly? Well, a similar problem can occur. If the esophagus can't push the food through, it can't push the acid through, then you're going to experience heartburn. So you may have a normal amount of reflux. Everybody refluxes between 24 and 50 times a day. That's normal. A little bit of fluid from your stomach refluxing up into your esophagus. But those of us that have a strong esophageal muscle will be able to push that acid material back into our stomach. If you have poor motility of your esophagus, you won't be able to push that material back into your stomach, and it will result in heartburn. This can also lead to dysphagia, or difficulty swallowing, because as you swallow, your esophagus is not pushing the food along like a snake would, and it's getting stuck. When your food gets stuck, that can also cause inflammation, and as we already know, inflammation can lead to scarring. So what about respiratory problems? How about those of us that get chronic bronchitis, have had onset of asthma as an adult, which is very unusual, or even have gone on to have more severe conditions in their lungs called pulmonary fibrosis, or scarring of the lungs? Why does this occur? It occurs because the trachea and the esophagus are very close in proximity to each other in the back of our throats. So that when you're unable to completely clear the acid from the back of your throat, it may drip slowly into your trachea and eventually seep into your lungs and cause inflammation and scarring. Similarly, it can pool in the back of our mouths and cause ear infections, hoarseness, and sore throats. So what happens if you get inflammation in your esophagus? Well, in general, nothing. You have it, you have the pain, and most of the time, it's either going to stay there and get no worse, or maybe eventually go away. But in few people who either have a gene that we have yet to identify, or have some other predisposition that we don't totally understand, you may go on to get what's called Barrett's esophagus. And it's a brilliant thing that the body has done here. So the body has decided that having a lot of acid refluxing back up from the stomach into the esophagus, or even bile or pancreatic juices, is harmful to the esophagus, and it's not happy with that situation. So the body's decided to replace the esophagus with colon cells because, of course, we know the colon is resistant to lots of very toxic substances and seems to fare just well. So the body thinks, well, if I replace the esophagus with colon cells, then the esophagus itself will also be resistant to acid and bile and other chemicals that get introduced from the stomach into the esophagus when you have reflux disease. That sounds like a great idea, but the problem is that the body doesn't know when to shut off the development of the colon cells. And so you get something called Barrett's esophagus. And over time, if the cells continue to divide abnormally, you actually can get what we call dysplasia. Dysplasia is where the cells are on a total random, irregular pattern. And if that goes on for a long enough period of time and has continued exposure to acid, then we have high-grade dysplasia or early-stage cancer. So you can see in this picture the very healthy pink esophagus and then the beefy red area that we know as Barrett's esophagus. And undoubtedly, in this particular specimen, there is likely to be some degree of dysplasia from the cells sort of running awry and not knowing when they should stop producing themselves like colon cells. Barrett's esophagus has a real risk of going on to become adenocarcinoma, or cancer of the esophagus. In fact, you have about a 40 times the risk of the normal population if you have Barrett's esophagus for any significant amount of time. It's about a 2% risk per year that you have Barrett's esophagus. So while Barrett's esophagus itself is uncommon, if you do have it, every year you harbor a risk of about 2%. Now, much of this data was collected more than 10 to 15 years ago when there were no treatments for Barrett's esophagus. But fortunately now we have some very good treatments for Barrett's, and if you happen to be somebody that actually gets Barrett's esophagus, many times we can now eradicate it so that your risk of going on to get cancer is much lower than 2%. So just briefly, let's talk a little bit about what is cancer of the esophagus and when do we have to start to worry about it. Well, traditionally, the most common type of esophageal cancer was squamous cell cancer. And this was not related to reflux disease. In fact, it's related to people who smoke or drink heavily. So if you didn't have reflux disease, you still have a chance of getting cancer of the esophagus, just a different type if you're abusing your body with other chemical substances. But by far the most common type of cancer in the United States is adenocarcinoma. It accounts for about 70% of all the cases that we see, and it has a link to Barrett's esophagus. So we also know then that it has a link to reflux disease. And although the link is not well established in terms of how it actually occurs, there are some very good theories out there that it's due to ongoing exposure to either acid or bile reflux. It has become such an epidemic that now in the last few years it's become the 6th most common cause of cancer worldwide, and it is the most rapidly increasing cancer in the United States. There are about 15,000 new cases diagnosed every year, and unfortunately only about 10,000 of these cases, only about 5,000 of these cases, will actually be amenable to any kind of treatment. The esophagus is very pliable, and so when you have a small tumor growing inside, it accommodates for it. And it's not until the tumor is quite large that you'll actually have symptoms significant enough where you might go to the doctor. And by that time, it's often too late. So how did this all sort of come about? We can see that in the years since the 1970s, there's been a significant increase in adenocarcinoma. So what's changed in that period of time? There was a really good study that was done in the late 90s that showed that most patients who have adenocarcinoma actually also have reflux disease. So what else was it about patients that had reflux disease that maybe predisposed them to going on to get cancer? Well, they were also being treated for reflux disease. So prior to the 1970s, if you had heartburn, you drank, sodium bicarbonate. 1970s, then we started having other medications such as Pepcid and Tagamet come out, and patients started taking those very effectively to treat their symptoms. By the 1980s, we then had the other medications such as Prevacid, and those medications have contributed to being able to manage our reflux disease. In other words, it's taken away all of our symptoms, but it's also been correlated with an increased risk of adenocarcinoma of the esophagus. This is what adenocarcinoma of the esophagus looks like. It causes lumpy, bumpy tumors in the esophagus that make it very difficult to eat. The strictures then make it so difficult to eat that eventually you lose a significant amount of weight. And weight loss is one of the early signs of esophageal cancer. Weight loss that you're not trying to manage. So in summary about the complications, we can get esophagitis, which is just inflammation from the ongoing exposure of the esophagus to acid and other substances in the stomach, such as bile. That inflammation then will cause strictures or narrowing. There can also be a loss of muscular strength of the esophagus, so that you don't have a proper squeeze. You can also have difficulty with clearing the esophagus of its acid, also causing heartburn. There's respiratory problems with asthma, chronic bronchitis, ear, nose, and throat problems, and then, of course, Barrett's esophagus, and then lastly, cancer. So what are the treatment options? Now that I've sort of scared you with the options of treatment, saying, well, it could potentially have caused cancer, what are some of the other things that we can do to prevent ourselves from having ongoing reflux disease? Well, the first thing is diet modification, and it's significant, and it's different for everybody. So if you were to go online and take a look at what you're supposed to avoid if you have heartburn or GERD, you're going to be told to stop just about everything that you enjoy. So it's not a realistic approach to controlling your reflux disease. But if you can find 1 or 2 or even 3 trigger foods that seem to bother you, then you can sort of manage your reflux disease so that perhaps you wouldn't need to take ongoing medication. Instead, when you decided to treat yourself to a lavish, spicy dinner with lots of wine and tomato basil pasta, you could take your medication prior to that to sort of protect yourself around that time. But you wouldn't be subjecting your body to having an ongoing suppression of acid. Instead, you would allow your body to normally neutralize the way that it always does and maintain a normal pH between the acid and the base that it normally has. But at times when you wanted to be a little bit cheating here and cheating there, you could go ahead and take your medications. So diet modification is definitely an option. It's just a difficult option, and most of us are not that disciplined to maintain this on a daily basis. Sort of going along with that then is also eliminating large meals. So obviously weight loss weight gain is a risk factor for heartburn because it causes pressure in the esophageal sphincter. It causes it to pop open. It can also induce hiatal hernias. So avoiding large meals where you're not filling up your stomach so much and not creating so much gas in your stomach can also prevent heartburn and reflux-related symptoms. But it's also difficult to be disciplined enough to not eat large meals on a regular basis. So most people are going to have to resort to medications. I put this slide in because, there are alternatives. You could eat grass and tree bark. That's what animals do. You rarely see animal models with reflux disease. But, it's probably not so tasty, and you might prefer to just take your medication. There are other options for nighttime symptoms, such as putting a wedge underneath your pillow or underneath your mattress to try to help you manage regurgitation and heartburn that you might have at night. And of course, the antacid medications, the H2 blockers, and the proton pump inhibitors are all very effective in relieving your heartburn. They're not so effective in relieving the liquid. So if you're one that suffers with liquid that comes up into your esophagus, and sometimes you can actually taste it or feel it in the back of your throat, these medications are going to help very little with that, as probably many of you have experienced. So what else can we do? Well, we can reduce the acid and the pain by taking the medications, but that's going to be limited. All of these medications, which help, are an $8 billion a year industry, which is why it's pushed so much. But there are other better options for people who have ongoing problems with heartburn. So let's investigate a few of those. The first thing to realize is that the medications won't fix all the problems associated with reflux, but they are very good for treating many of the symptoms. So the first place to start is diet modification, small portions, and intermittent medication. When you get to the point where you need daily medication to control your heartburn and your reflux, then you should seek out the advice of a doctor that specializes in this area so that they can help manage your medications and determine whether or not a bigger workup is required. We have to determine whether or not you're having problems with your esophagus, if the pump isn't working well, if the valve isn't working well, or if your stomach is not emptying. We actually need to treat the problem, not just the symptoms. And the problem is always with the valve. So there are some new techniques out there that are non-invasive, meaning, or I should say minimally invasive. They're procedural based. It is similar to going into the outpatient procedure unit and having a colonoscopy or an endoscopy. And during that period of time, they can do things to your esophagus to try to help fix the problem with the valve. And then there's also surgery, which many of you probably are aware of. It's done minimally invasively. It does require a general anesthetic in the operating room and an overnight stay in most cases. There are a myriad of endoscopic techniques. At this time, there isn't a single endoscopic technique that has really proven to be very good at treating the symptoms of reflux without also causing problems that down the road you probably wouldn't want to have. One of the techniques that is fairly common and also pretty good at treating the problem but not creating lots of problems down the road is called stretta. It's a high-frequency radio wave that gets beamed through the bottom of your esophagus through a probe that looks just like this, and it creates a scar. The scar is controlled to some degree. They can determine how much of a scar they want to create based on how floppy your valve is or how incompetent your valve is. And then the esophagus will be permanently scarred in that position. The good part of it is that it's minimally invasive. You go home the same day. And most of the time, about 70% of the time, you're going to have a pretty good result. It may not resolve all of your symptoms 100% of the time, but it's likely to get you off of your daily medications and put you into the category of needing intermittent medication. The problem is what happens if they scar it too much? Well, there's nothing you can do about that. So if the amount of radio frequency that's delivered causes a very big scar inadvertently, then you're going to have difficulty eating after that and require multiple interventions to have your esophagus stretched back open in an effort to try to eat again. So while this particular model has been successful in treating patients with some mild to moderate degree of reflux, it's been not so successful in treating patients with severe reflux because the amount that they've needed to burn in order to make that scar has been poorly regulated and created patients having significant scarring and difficulty eating. So it's probably not something that I would recommend that you go out and try to find somebody who does it. And you might have difficulty because not that many people do. And usually if there's a technique that not that many people do, it's probably because it's not that good. So I wouldn't recommend it, but for certain people that have significant other medical problems. So, for instance, you may have significant heart problems or significant kidney problems or even significant lung problems that would prevent you from safely undergoing an operation. So this would be a very good alternative in that case for you to try to consider for moderate reflux symptoms. It's a very short procedure. It takes about 1 hour. It's about 75% successful, like I said, and it's best for mild to moderate. There are other minimally invasive procedures as well, but none of them has even come close to what the Stretta device has been able to do. And so we're not going to talk about them here today. If there were to be something out there that you were interested in, you saw on the news program or you found reading in a magazine, please contact me and I will let you know what I think about it before you go in to get an opinion about that particular procedure. There are things being developed all the time, but there isn't anything out there yet that I would recommend. So let's say that you are one of these patients that has ongoing heartburn, and you tried initially to modify your diet, lower your portions, maybe lose a little bit of weight, and then intermittently spot dose yourself with medications. And it didn't really work. You're having daily heartburn, regurgitation, you wake up at night, you have pain or coughing, or your horse is getting progressively, your voice is getting progressively hoarse. What I would recommend then is that you go in and you have a consultation to see whether or not your problem would be amenable to surgery. And there's a variety of tests that we would put you through, none of which, I will warn you in advance, is very comfortable. But it wouldn't be going to the doctor if you went away feeling really good about yourself. You always kind of have to come away thinking that there's always something I have to do that I'm not doing well. So these 4 procedures, one is an endoscopy where you will be put out under a light anesthetic to take a look at the inside of your esophagus and make sure that you don't already have Barrett's esophagus. The second test is a barium swallow, where you'll drink some barium and take some pictures, and we can get a good idea of the function of your esophagus and whether or not you have a hiatal hernia. The last 2 tests are small little catheters that go into your nose and sit and rest in your esophagus. One probe you'll go home with for 24 hours, and it'll measure all of the acid that is exposed in your esophagus over a 24-hour period of time. And the other is a catheter that will measure the pressure in your esophagus and the valve to determine if you have a problem in your esophagus or just your valve. If we look at these tests and determine that you may benefit from surgery, then we may recommend what's called a Nissen fundoplication. Fundoplication is just a fancy term for wrapping part of the stomach around the esophagus, like a hot dog in a bun, to create that pressure valve that we need, that you lack. It's done through a couple of very small little incisions, so that many times when you come back to see me in the clinic, 6 months later, we can't even find all of them. Like I said, it takes the top part of the stomach and it wraps it around the bottom part of the esophagus, creating this valve. So this is a schematic, and it's exactly what it looks like when I leave the operating room. It's all done minimally invasively or laparoscopically with cameras, a few small incisions. It generally takes less than 2 hours to perform, and most times an overnight stay. It's fairly quick return to work, and as long as you're not lifting refrigerators at work, in which case then you have about a 6-week hiatus from work. And it's 90% effective in restoring the barrier to reflux so that you won't have to take any more medications. On occasion, you may still even experience heartburn, and that's because all of us do. It's normal to have 24 to 50 episodes of reflux a day in the normal population. So when we do this surgery, we're trying to make you as close to normal as possible. And in an effort to allow you to be able to belch and even throw up if need be, we don't always wrap it so tight. We leave it just tight enough so that it eliminates the acid on an ongoing basis, but still allows some relief of the valve to allow gas and even sometimes acid to go back up into the esophagus. Because it creates a barrier to ongoing reflux, it will decrease your chances of getting Barrett's esophagus and going on to get cancer. You may not be one of those individuals that has a risk factor for Barrett's, and if you don't, then it doesn't change your risk. But if you are an individual that may be at risk for Barrett's, of which we don't really know what those risks are, then it will decrease your chances of going on to get cancer. In addition to that, if you already have Barrett's, you can be treated for your Barrett's, and if you undergo this procedure, then it'll prevent you from getting Barrett's back. It'll restore that barrier so that once you've eliminated your Barrett's, it shouldn't come back. Furthermore, if you have dysplasia, or those irregularly lined cells in the Barrett's itself, if we do this procedure, it will allow those dysplastic cells to repair themselves and to become normal looking. So there's many benefits to the surgery that you wouldn't have with the medication. It takes away the pain, it takes away 90% of the symptoms. It prevents ongoing reflux, and it will also help in preventing esophagitis, strictures, Barrett's esophagus, and going on to get cancer. And this is because it treats the problem. The problem is with the valve, not just the symptoms. So in summary, reflux is a serious medical condition, much more than just heartburn. Many patients, as we've just learned, don't even have heartburn. It can lead to esophagitis, strictures and narrowings, Barrett's esophagus, and cancer if it's left untreated. Medications are helpful. They treat the symptoms, and in most cases, that's all you'll need. But it doesn't treat the problem, even if it does treat the symptoms. Medications also will not reduce your risk of developing Barrett's or cancer. But minimally invasive techniques, such as the laparoscopic Nissen fundoplication, can protect against the complications of reflux disease and take away your symptoms. So what treatment is right for you? Well, diet modification does help, and it works in many instances to relieve the majority of your symptoms, but it is not going to be something that you can expect to be 100% disciplined with and have 100% success in eliminating your symptoms. Medications are the perfect adjunct to that. So like I said before, plan your binges and then take your medications. Treat yourself to a pain-free spicy dinner by loading up on your medications right around the time of your indulgences. Take a look at some newer endoscopic procedure for those of you that have mild to moderate reflux. You may be a fit if you have an aversion to undergoing a surgical procedure with general anesthetic, or perhaps you have medical conditions that would prevent you from being able to do that. And finally, get an opinion about whether or not the Nissen fundoplication might be right for you. And I ask that you go and see a surgeon to get a surgical opinion, because if you see a medical doctor, of course, it's difficult for them to give you a surgical opinion. So best to leave that up to the surgeons. If you think that you're being treated and managed well, you may not need a surgical opinion. On the other hand, surgery may be the relief that you're looking for so that you no longer have to suffer and continually take your medications. So that is gastroesophageal reflux disease in a nutshell, and I'm happy to entertain any questions you may have. The question is, as we get older, we change the amount of acid that we're producing, and is there a test that we have that allows us to measure that? The best test for measuring acid in the esophagus is the pH probe, where a small little spaghetti strand is put down your nose and placed into the esophagus. There are other tests that you can have to measure the amount of acid output in the stomach, but that would probably be the most sensitive test to determine whether or not it's actually causing problems with reflux disease.
I was told that I should take omeprazole for the rest of my life. My GERD is not extreme. I decided to try to control it with diet. Is it reasonable to take omeprazole for the rest of your life?
Is it reasonable to take omeprazole for the rest of your life? I think that it's not known as to what the effects of long-term, for the rest of your life, side effects may be from taking ongoing medication like that. But I think it's reasonable to take it. Right now, we don't have any indications that the risks outweigh the benefits. But I don't think it's necessary. I think that unless you have very significant symptoms that can't be controlled by some diet and weight modification, then you maybe need to investigate why that is to see if there's another fix for it as opposed to just doing lifetime omeprazole.
I can pretty well, if I start to get it in the evening, if I eat maybe apples, or if I chew gum even, or if I sip on very hot water, it seems to control it. So I would think that omeprazole for the rest of my life would be a little extreme.
Yeah, I don't think it's necessary. I am not a fan of just putting on medications without a real understanding of what we're treating. You may not have significant acid reflux, in which case you're taking medications for no reason, but we wouldn't know that unless we actually did some tests to investigate if your symptoms are being caused by acid. They may not be.
Mary, I was seeing a gastro doctor, and he did the endoscopy and colonoscopy, and there was inflammation of my lining, and he put me on medication, and it was tearing at my stomach, and I couldn't take it. So I got frustrated and kind of just forgot everything, and then I went back because I started getting more pains, and he did an ultrasound, and after coming here, because I've kind of like just let it go and not really doing anything, but I'm still having symptoms. So are you a surgeon, is that correct?
Yes, I am.
So can you, so you're the one that would do the surgery, and a gastro doctor would do what? He's just finding the symptoms, or what can you explain that to me?
Well, I mean, traditionally anyway, the gastroenterologist would do an endoscopy and evaluate you for your symptoms and perhaps treat you even for your symptoms, although many times the primary care doctor will sort of do the maintenance of those symptoms once the gastroenterologist has prescribed a particular treatment plan. But because I'm a foregut specialist, I actually don't refer to the gastroenterologist for the endoscopy or the maintenance. I usually do all of my own endoscopy, my own evaluation, and then ongoing treatment for reflux disease. But traditionally, anyway, that's where the lines between the surgeon and the gastroenterologist have been drawn.
Thank you.
You're welcome. So the question is, other medications, how much of an impact do they have on reflux disease? There are some medications that have significant impact. So not common medications, but if you're on steroids, so that would be prednisone, even a steroid inhaler, these medications can most definitely cause the sphincter to loosen up. There are other caffeinated products that you might take for migraines that can also cause reflux symptoms. In general, though, the most common reason why medications would be causing reflux disease is that you're taking 12 medications all at once. And that big pill overload causes a significant amount of fluid to dump into the stomach, and that can cause reflux. So the better thing is to just take your pills spaced out throughout the entire day, even if they're prescribed for you to take morning and night. Just do your best to sort of manage your once-a-day medications and put them towards the middle of the day so that you're not taking a big slug of pills in the morning and then again at night.
Thank you.
Mm-hmm. So this is a question about the transoral incisionless fundoplication, and this is an endoscopic procedure that is done in the operating room, oftentimes with laparoscopic assistance, but not always. And basically what that is where they take a big endoscope, so it's much bigger than the average endoscope, and they put it into your esophagus, and they twist the top of your stomach and pull in with stitches to try to tighten the valve. And it's been around on and off for more than 5 years, actually. And there are now several centers in the United States that are spearheading the effort to do some very good research and get some good publications out there on it. And so far, the data that's there demonstrates that in some individuals, it will be a good procedure. However, in the majority of individuals, it's likely to cause problems down the road that are then going to require surgical intervention to correct. So I myself, when I was director of the Esophageal Center at UCLA, had many referrals for complications from this procedure. So many people who had the procedure done, their symptoms went away for a few months, then the symptoms came back, and then they had other bigger problems that I would then have to take them to the operating room, rectify the symptoms, and then even perhaps then perform a fundoplication on them. So it is an endoscopic procedure that is likely to find a niche, and I think that it still needs another 2 to 5 years to look at the data to determine whether or not it has an equal benefit to surgery or medical treatment before we can strongly recommend it.
I have a problem with problem with heartburn, and the doctor put me on Esophageal. And then after a period of time, I was very successful with controlling the heartburn. But after a period of time, he wanted me to go every other day with the Esophageal because he said that it can cause osteoporosis. Is that a fact, or is that?
There was a study that came out that demonstrated that more than 20-year use of once-a-day dosing of omeprazole or one of the H2 blockers can lead to osteopenia, which is where you begin to have a lack of calcium buildup in your bones, but not osteoporosis. So unfortunately, the way that the press picked it up, the study, they completely misworded the information. But could it eventually lead to osteoporosis? Well, osteopenia can lead to osteoporosis. But the best thing to counteract osteopenia is exercise. So, if you think that you have heartburn that's bad enough to be treated with medications and you don't want to get a surgical evaluation, then just go out there and exercise 3 times a week and you'll counteract the osteopenia that you may get or may not get from taking your medications.
How long should you be on medication for GERD before you should ask your doctor, or your doctor should suggest that you get tested? And what is the first test that you recommend?
If you've been on it for more than a year on a daily basis, you should go and get investigated. Yeah, more than a year. If you're on it every day for more than a year, you should go in. And the 2 tests I would recommend you get right away are, one is an endoscopy to make sure that you don't have Barrett's esophagus. And the second thing is to get that pH probe test that will then measure the acid so that you can determine if there's acid. And then from there, you can get the other 2 tests if necessary.
If you have a hiatal hernia once, do you always have it, or does it ever repair itself?
It never repairs itself. It can be repaired, and if you are overweight, the chances of it coming back are very high. So in general, if I have patients that come to me that have hiatal hernias and they're overweight, I make them lose the weight first, and then we fix the hiatal hernia, and it should stay away forever.
For people that have had surgery to reduce the size of their stomach in order to lose weight, and where then the amount of food you eat after the surgery is supposed to be quite important in keeping it small, does that in any way affect whether a person is likely to get GERD or acid reflux problems?
No, usually weight loss surgery does not increase or decrease your chances of having reflux disease. No bearing.
If one is diagnosed with hiatal hernia and don't have too many of these symptoms, is it necessary to have the surgery?
The question is, if you have a hiatal hernia and you don't have symptoms, is it necessary to have the surgery? The problem with hiatal hernias is that over time they tend to get bigger. And they can become so big that then there's a real health risk where the stomach can actually rotate and the blood supply can be shut off to the stomach and it can die in your chest. And if that happens, you will not make it to the emergency room. So most of the time, hiatal hernias stay relatively small. And as long as they're not causing problems, you can safely leave them alone. But you should have them followed to know that they're not getting bigger. So, it's hard to say for sure, but in a heavy person, I would say yearly barium swallows to identify whether or not their hiatal hernia is getting worse. But in a thinner person, probably maybe every 3, maybe even every 5 years would be safe enough to just make sure that your hiatal hernia is not getting any worse.
Dr. Maish, thank you so very much.
You're welcome. Thank you. You're a great audience.